Have you ever stood in front of two seemingly similar options, knowing that your choices could impact your finances for years to come? That is exactly what happens when you're trying to decide between Medicare Supplement Plan N and Plan G. These two popular Medigap options, they look almost identical at first glance, but the differences between them could mean the difference between thousands of dollars in your pocket or thousands spent unnecessarily. I'm Cameron Giardini from Giardini Medicare, and at our family-run independent agency, we have helped thousands of Medicare beneficiaries make the exact decision we're going to talk about in this video. Today, we will walk you through everything you need to know about choosing between Plan N and Plan G with confidence. Before we get started, real quick, I want to invite you to scan the QR code you can see here on the screen, or you can click the link in the description of this video to join our private Medicare Q&A Facebook group. There, we can answer your specific Medicare questions that you might have after watching this video. For all other questions, you can always comment them below, and also please let us know after watching this video if you would choose Plan N or Plan G. Let's get started with the basics. Medicare supplements, also called Medigap plans, they are sold by private insurance companies, and they are designed to fill the financial gaps in original Medicare coverage. With either Plan G or Plan N, original Medicare, which is Part A and Part B, that remains your primary coverage. Your Medigap policy then serves as secondary coverage. You can see any provider in the country that accepts original Medicare, as long as they are willing to accept you as a new patient, of course. Medigap plans are standardized by plan letters, with plans sharing the same plan letter offering the same basic benefits regardless of which insurance company you choose.
That does not make it easier.
Now, some insurance companies, they might offer additional perks like fitness memberships or dental and vision benefits, but for the sake of today's comparison, we are only focusing on these standardized core benefits that make up Plan G and Plan N. Before we talk about what makes these two plans different, let's discuss what they have in common. Neither Plan N nor Plan G covers the Medicare Part B deductible, which is $257 for the year in 2025, which is up from $240 in 2024. This means you are responsible for 100% of Medicare approved cost until you meet this deductible, regardless of which plan you choose. The good news is that most preventive services are fully covered by original Medicare at no cost to you without applying to the deductible. On the screen right now, you can see a chart from the Medicare and You Handbook showing the coverages that these two plans share. Take a moment to look that over. You might also notice some key differences between them, and that is exactly what we will discuss next. Once you pay your Part B deductible, Plan G covers all remaining costs for Medicare-approved procedures. It's that simple. Plan N, however, does leave you with some potential out-of-pocket costs that don't exist with the Plan G. First, with Plan N, you'll have two types of copays. Up to $20 for doctor office visits, which includes both primary care and specialist visits. Also, up to $50 for emergency room visits, which is waived if you're admitted as an inpatient following the ER visit.
Oh man, I can't afford no Medicare copayments!
To figure out what specifically causes the Plan N copays, we can look at the FAQ guidance from the National Association of Insurance Commissioners. This document has been the go-to for most brokers for years. And you can see here the specific CPT billing codes that cause the $20 office visit copay and the $50 ER visit copay. However, there's one problem you might notice when you look at this document, and that is that it's 15 years old and it simply has not been updated since. Some examples of things that have changed after this guidance was released include the Office Visit 99201 CPT code, which was eliminated in 2021, and the fact that the 99211 CPT code is much less commonly used now. Also, when it comes to psychotherapy, the 90805 code was eliminated in favor of a wider range of codes from 90832 to 90838. Specifically, in this range of new psychotherapy codes, 90833, 90836, and 90838 have an evaluation and management component. Now, you don't really need to know what this is, but just know that this is why they are more likely to cause a Plan N copay based on the research that we've done.
Man, do I have a headache.
However, we have not personally seen all of the copays with various psychotherapy visits with our own eyes, so we really can't say which ones do or do not with certainty cause the Plan N copay. Please comment below though if you have experienced any of these copays personally for a psychotherapy visit if you're enrolled in Plan N. With all of that said, on the screen you can see our current best understanding of the specific CPT codes that lead to Plan N copays. Next, you should know that these copays, they only apply after you've met your Part B deductible. Let's show you how this works in real life. On the screen now is an explanation of benefits showing a real office visit with CPT code 99213. This should result in a Plan N copay based on what we talked about, but since the deductible has not yet been met, you have to pay the full Medicare approved amount of $85.63 for the visit and not the additional $20 copay on top of that. Sometimes you might also go to the doctor when you have a small amount of your Part B deductible remaining, and in that case, you may pay a mix of the remaining deductible plus a portion of the Plan N copay. You can see an example of this on your screen now. It's crucial to know that the actual copay amount you pay is the lesser of the maximum $20 and $50 or the actual Medicare Part B coinsurance. Let me show you two examples to make sense of this.
Show me, please.
Here's a case where 20% of the $92.70 Medicare approved amount for an office visit ends up being $18.55. As you can see, this is less than $20. So the billed copay amount is $18.55 and not the full $20. Now here's another example where the coinsurance is more than $20, but again, the copay is capped at that $20 limit. Despite what the older NAIC guidance document says, telehealth and urgent care now often do see the same office visit codes as regular doctor visits, which means they can cause Plan N copays, so just be aware of that. Now on the other hand, physical therapy often uses different CPT codes than physician office visits, so they typically will not result in a $20 copay like many people are afraid of. Now, a question we received in our past Plan N versus G video is, can these copays change in the future?
Good question.
Technically, yes, but they have not changed in the last 15 years, and any changes based on our knowledge would require legislation being passed by Congress. Even then, we don't know what these changes might look like. They could only apply to policies sold in the future and not existing ones. We are yet to see any indications of these copays being changed anytime soon, but with that said, if the thought of these copays possibly changing in the future keeps you up at night, no matter how unlikely it is, Plan G might simply be an easier option for you. Now let's talk about Part B excess charges. This is likely the most significant and most misunderstood difference between Plan G and Plan N. Nearly everybody has experienced copays at some point in their life, so paying a fixed amount for a doctor visit, it feels normal. But excess charges are much different from anything you've probably experienced before Medicare eligibility. Here's how they work. Participating providers accept what is called Medicare assignment, and therefore they cannot charge excess charges. Non-participating providers, on the other hand, are a different type of provider who are still contracted with Medicare, but they don't accept Medicare's payment as full payment, and therefore they can charge you excess charges. You can often find out if a provider is participating or non-participating by using the Medicare.gov provider lookup tool. Or you can also try asking their billing department if they accept Medicare assignment.
Do you accept Medicare assignment?
But be careful and make sure the person you're talking to knows exactly what you're asking. Non-participating providers, they can charge you up to 15% above the Medicare approved amount. This is what is known as the excess charge. But there is an important detail in how these charges are calculated. Non-participating providers, they agree to take 95% of the normal Medicare approved amount, then they can add up to 15% to that reduced amount. So this means, based on the math you can see here, is that they are effectively charging 9.25% above what a participating provider would receive, and they are not simply collecting a straight 15% extra. The key difference: Plan G covers excess charges completely. Plan N does not. This leaves you responsible for the full excess charge amount if it occurs. And an additional thing to be aware of is the 15% limiting charge that we mentioned does not apply to durable medical equipment. So if you do need any DME supplies, make sure you use a participating provider. Given all that information, should you worry about excess charges?
Tell us how to feel.
Although we can't tell you how to feel, here are some key things to consider. 98% of physicians billing Medicare are participating providers, according to CMS for 2025. Also, according to MedPAC in their 2025 report, they show that in 2023, 99.7% of Medicare claims were paid at the standard Medicare payment, which means there were no excess charges associated with them. You may wonder why more providers don't charge excess charges if they can, and one possible reason for that, despite the added revenue, is due to the fact that non-participating providers, they do face some challenges, such as slow claims processing and potentially worse patient experiences, since many non-participating providers can charge the patient the full bill up front, causing the patient to have to get reimbursed by Medicare and their Medigap insurance company, which is not something that a lot of people want to do. However, some specialists are more likely to charge excess charges, including psychiatrists, based on our personal experience. In fact, on the screen, you can see one of the only examples of excess charges that we have actually seen from one of our clients, and it was due to a visit to a psychiatrist. Several states, known as MOM states, they prohibit excess charges entirely. You can see these states here on the screen. Technically, New York does allow excess charges up to 5%, but that is so small that it makes very little financial sense for a provider to actually bother with it. Lastly, here is an interesting example. In Wisconsin, they have much more customizable Medigap plans, and you can see here how this specific Medigap company values coverage specifically for Part B excess charges, and you can see this ranges from about $6 to $12 per month. In our opinion, this shows the relatively small risk that insurance companies and their trained actuaries believe excess charges pose. Overall, again, if you're worried that doctors might stop participating in Medicare due to funding changes or other factors in the future, you simply might feel more comfortable with a Plan G. We're only here to present the facts and the numbers and not tell you what you should or should not be personally comfortable with. But before we move on, in order to truly understand excess charges, let's look at some more realistic examples of what these might look like in real life. Using a total knee replacement with CPT code 27447, the total Medicare approved amount at an ambulatory surgery center might be $10,512. This breaks down to $9,255 as a facility fee and $1,257 for the doctor fee itself. Now you might be sitting there thinking that excess charges would apply to the full $10,512, but federal guidelines, they require ambulatory surgery centers to accept Medicare assignment for their facility fees, as you can see. Therefore, potential excess charges, they would only apply to the doctor's fees. And this is, again, only if the surgeon or anesthesiologist are non-participating providers. It is also very unlikely that there would be excess charges at a hospital outpatient department. Let's walk through the math, assuming you've already met your Part B deductible. The $9,255 facility fee, again, has no excess charges associated with it. Medicare does pay 80% of this amount, which is $7,404, and both Plan G and Plan N would pay the remaining 20%. Now for the $1,257 of the doctor fee, if it's a non-participating provider, they would accept 95% of that larger Medicare approved amount, so instead they would accept $1,194, and then they can charge 15% additionally to that amount. This would be an additional $179.10. In this case, the total the provider would collect would be $1,373.10. Medicare reimburses 80% of that smaller $1,194 amount, and then your Medigap plan would cover the remaining 20%. Now, like we mentioned, with Plan G, your Medigap plan would also cover the excess charges completely, leaving you with $0 out of pocket. With Plan N, on the other hand, for this total procedure, you would likely be responsible for the full excess charges of $179.10. There is also an additional protection that is worth mentioning. For elective surgeries costing $500 or more, non-participating surgeons must provide certain information in writing to Medicare beneficiaries before the surgery. Let's look at a final example that people often bring up. Chemotherapy. Some people, they like to talk about a hypothetical $1 million cancer example, and it just seems like a scare tactic at this point. But in reality, excess charges, they only apply to the provider fees for administering the chemotherapy drugs, not the actual medication costs, which make up the bulk of chemo costs. Again, according to federal guidelines, chemotherapy drugs, they are typically reimbursed on the average drug pricing and not the Medicare physician fee schedule. So while chemotherapy drugs can cost tens of thousands of dollars, you would likely only pay excess charges on the physician's administration fee. If we look up the normal CPT code for chemotherapy 96413, the potential excess charge for a 1-hour treatment is approximately $11. Now, there also may be excess charges for the office visit itself, but again, that is much lower than what people like to make it seem, where you're paying 15% of $1 million. With everything we talked about, why would somebody opt for Plan N and deal with copays and excess charges and all this uncertainty? Well, as with anything in life, it comes down to cost savings. And again, this is compared to Plan G, both short-term and long-term. On your screen now, you can see a map showing typical Plan G versus Plan N monthly premiums for a 65-year-old in each state across the country. The median Plan N premium is $35 less per month than Plan G. In addition to lower initial premiums, Plan N often experiences smaller annual premium increases compared to Plan G. Based on our internal analysis of dozens of different Medigap companies nationwide over several years, Plan G premiums increased by an average of 6.5% per year, with Plan N premiums increasing by an average of 4.5% per year. To be clear, these averages, they include several years with lower increase trends, so they're actually lower than the average increases we have been seeing in 2024 and 2025. But we can't change our long-term projections based on just 2 recent years of higher than normal increases. Since we didn't want you to just take our word for it and rely on our premium increase data, we also looked at average increases reported by Telos Actuarial, which you can see here on the screen. According to Telos, from 2021 to 2025, Plan N increased by about 7.6% per year and Plan G by 9.1% per year. And just know this is based on our best judgment of what the chart is showing, since it's not specifically listed. But why does Plan N typically see these smaller increases than Plan G? There are a couple of reasons. Plan N tends to attract healthier members because of its cost-sharing requirements. For example, copays and excess charges, they can simply scare away consumers that have higher or more consistent healthcare needs, whereas consistently low out-of-pocket costs of the Plan G are more appealing to those same people. Plan G is also a designated guaranteed issue plan for those eligible for Medicare after January 1st, 2020, while Plan N is not. In certain situations, guaranteed issue rights, they allow consumers to enroll in Plan G without medical underwriting or being denied due to pre-existing conditions. These same guaranteed issue rights are often not available for Plan N. This, again, forces some people with more costly health conditions to enroll in Plan G. Let's look at some real numbers to see how these differences might play out over time and bring this all together. We will project costs from age 65 to age 85, which ends up being a full 21-year period. For our first projections, we are using our internal Medigap increase averages of 6.5% for Plan G and 4.5% per year with Plan N. We are also assuming the following. Starting premiums for Plan G, $135 per month versus Plan N at $100 per month. as well as annual Plan N copays of $210, and we are assuming the full Part B deductible is met for each plan letter each year. You can see the results of these projections on your screen. Over this 21-year period, Plan N would save you an estimated $23,655 compared to Plan G. That is an average yearly savings of $1,126. For our second projections, we'll use Telos Actuarial's average premium increases instead. We are also assuming Plan G starts at $135 per month versus Plan N at $100 per month. And again, we assume the same $210 of Plan N copays and the full Part B deductible being met. Looking at the chart on the screen, over this 21-year period, using Telos's average increases, Plan N would save you an estimated $30,918 compared to Plan G, which ends up being an average yearly savings of $1,472. But you might be sitting there still wondering, what if Plan N increases don't end up being lower than Plan G?
Then what happens?
People often fixate on Plan N strictly having a lower increase trend than Plan G, and frankly, some of that is our fault for making videos like this one. But what if rate increases are announced and both plans have the same exact percentage increase, which certainly happens in real life? In this case, it can make you feel like you made the wrong choice. But did you? To test this, let's do a projection assuming both plans increase at exactly the same rate. For this projection, we're assuming starting plan premiums again of $135 per month for Plan G versus $100 per month for Plan N. Full Part B deductibles again are projected to be met each year, and for this, we are assuming a yearly premium increase of exactly 7% for both plans. We'll mention copays soon. The results show a difference of $18,843 over the 21-year period, or roughly $897 per year in savings with Plan N versus Plan G. This means that if we exclude excess charges in these projections, you would need to have over 44 office visits with a copay every year before Plan N becomes more expensive than Plan G. Put another way, even if you go to the emergency room without being admitted 5 times per year, you could still have 32 doctor visits with $20 copays each year before Plan N becomes more expensive than Plan G. For those of you that might be watching this and you have a smaller premium difference between Plan N and Plan G in your area, let's look at one final projection. In this case, we will assume Plan G starts at $125 per month with Plan N at $100 per month. And again, everything else stays consistent with the Part B deductible and the exact same premium increases of 7% for each plan. These results, they still show a difference of $13,459 over the 21-year period, which roughly breaks down to $640 per year. And again, this means that you would need to have 32 or more office visits with copays before Plan N becomes more expensive than Plan G. And again, even if you go to the emergency room 5 times a year, every year, you could still have 19 doctor office visits each year, resulting in a $20 copay before Plan N becomes more expensive than Plan G in this situation. Despite all of these potential savings with Plan G, according to Telos and their annual Future of Medicare Supplement report, approximately 85% of beneficiaries still choose Plan G over Plan N. And why is this? In our opinion, it comes down to a couple of factors. Number one, Medicare beneficiaries, they seem to receive less exposure to Plan N from brokers and insurance companies. As brokers, it takes more work to properly explain Plan G compared to Plan N, and Plan G even gives us higher commissions. These factors, they could lead to fewer people being made aware of the Plan N, although truly we do see that this trend has been improving in recent years. Second, and probably most importantly, many people, especially during retirement, they have a preference for predictability with Plan G's more comprehensive coverage. You may value the peace of mind that comes with never having to worry about copays or excess charges, and you may simply willingly pay more for that coverage. Even our clients and many people who watch these videos who fully understand the differences between Plan G and Plan N, they still end up choosing Plan G more often. Finally, remember that changing between Medigap plans after your Medigap open enrollment period, it typically requires answering medical questions and passing medical underwriting. So in many cases, deciding between Plan N and Plan G should be viewed as a long-term decision. Now, this will depend on unique rules in your state, such as birthday rules, anniversary rules, or other special Medigap enrollment windows, so we will link to a document covering those details below. Now that you're fully aware of the important differences between Plan N and Plan G, you can make an informed decision that fits your personal preferences, health needs, and financial situations. Do you prefer the low premiums and potential long-term savings of Plan N, even though it can mean copays and potential excess charges? Or do you value the complete coverage and the simplicity of Plan G, despite likely having to pay more for it? Don't forget about the high deductible version of Plan G, which could also be an excellent choice long-term. To learn more about how that stacks up to Plan G and Plan N, make sure you watch our video after this one next.